Last week, we talked about physical examinations, mainly in the chest and lung area. We still do some review first. Thoracics, just the chest area. And chest area, we have lung, and we also have heart. We separated to talk about these two organs because there are more examination ways in these two organs. With Sweartz diagnosis, we make physical examinations. We have 4 ways. One is looking. Two is palpation. Three is percussion. 4 is aspirations. So that's West medicine. We still have 4 ways to do physical examinations. So we say in some part of the bodies, like we talking about head and neck before, we only use 1 or 2 ways. Like in the head area, we just looking and maybe some palpation in there. Mainly is looking. But for the chest area and the lung, we have all 4 ways examinations. And also for the heart, we still have 4-way examinations. So that's why we separate these 2 organs. We use 2 classes. So checking for the lung and for the heart is very, very important in West diagnosis. We can get a lot of information coming from physical examinations only. And before we go to local chest area, we review some anatomy symbols in the local area. Thus, basically, it's easily for us. One is find the problems. One is record the problems. So basically, like the patient feel, maybe not looking by one practitioner or one doctor. Similar like our clinic, like a patient coming for acupuncture treatment. Maybe this time you treat, next time you may not available. They will looking some other students to treat. So that means what you find, you need a recorder in there. And also later on, like a patient have other sick or illness, then they can compare. Like some nodules in some special area, they can see like this year is 1 centimeter. But after 3-4 months, they may go upper to 4 centimeter. We can see the changing. So that's basically we need a recorder for special location. And like what we finding there. So that's we separate some location in here. We couldn't only say just in the chest. That's hard to find. Yeah. So that's basically anatomy superficial symbol, just easily for us to record. So that's basically we have some commonly used like anatomy words in here. Superior means above. Sternal notch just like a dividend here. Yeah, something we find in here. That's superior sternal notch. And still, superior medical words is upper. Yeah, upper. About clerical, in this area, we call it fossa. Fossa, if you go to that area, you can find a little bit dividend in there. So a little bit difference here, the notch, we're talking about the bone here. The fossa, we're talking about the bone, we have some dividend here. So that's superior clerical fossa. And we're talking about the sternal bone. That's a bigger bone composed by 3 parts right now. Originally, it's 3 bones. But when these 3 bones fall in together, we still can find the connected part. So that's one connected part in here, one connected part in here. These connected parts, they are not flat. The bone and the bone connected form an angle, like if you're looking from the side, pretty small, it's not that bigger. But you can find a small bump in there. So just like this, yeah, just like this. So that means in the superficial part, you can find a small bump in here and a small bump in here. So that we call angle. Above part, we directly call it a sternal angle. So these also pretty useful for our clinical practice. When we're looking for the intercostal space, like most of our points in the chest area, we say in the second intercostal space, third intercostal space, or fourth intercostal space. So how we calculate? We can find this sternal angle first, and below it is the second intercostal space, both sides. So intercostal space is below the ribs. Yeah. That's the first rib, that's the second rib. Below second rib is the second intercostal space. And then third intercostal space, fourth intercostal space. So that's another symbol. We calculate the ribs. And the lower one, we still say that's 2 bones connected each other apart, still form an angle, but a little bit small, So that's infra. Infra means low. We say super means upper, infra means low. Sternal angle, infrasternal angle. So that's clinically, for acupuncture, we still use it. We say from here to the umbilicus, that's 8 Cun. Remember, we calculate 8 Cun is not by the end of the bone here. It's by the connected angle here. It's about half Cun. This small bone here, exorbate process. So that's some symbol. When we're looking from the back, basically, we have a scapular bone in there, both sides. in the scapular bone, they have a process or spinal process here. So basically, it's a bigger bone bump in here. And then we can separate with two parts. Yeah, a bow part still cannot divide in there. We still call superior scalpel ridge. We use the ridge now. And the below part, we're talking about the infra scalpel ridge. So that's like we're looking for acupuncture points. Some points above this bone, some points below this bone. And another anatomy simple is we have vertebrae column here, and we have 12 ribs here. So this area still form an angle here, but we are not truly calculate how big the angle it is. Just this area, This area we call it costal spinal angle. Means rib and spinal form an angle here. So this area basically is our kidney located area. Later on, when we talk about checking the organs, when we checking the kidney, we looking this angle and find if patient has some painful in here, maybe kidney issue. Pretty much with our TCM. Like a TCM, we're still talking about lower back pain, kidney deficiency or kidney disorder. So that's area. It is our physical kidney located area. Then we're talking about some line. Yeah, in the chest we have middle sternal line, certainly in the pretty center and the center of the sternal bone. And also we're talking about the middle clavicle line. So middle clavicle line, basically, we find the angle of the clavicle bone in here, and then we will go to here. Yeah, two sides of the height of the clavicle, and then we find the middle. Then make a line, go down. That's the middle clavicle line. And the side part, we talk about, we use axillary. That's the anterior axillary line here. And certainly, when we go to the side, we have posterior and the middle axillary line. So that's the same line. We're looking from the front, we only can see anterior axillary line. But from the side, we can find on the posterior part of axillary, we make a posterior axillary line. And pretty in the center, we make a middle axillary line. So that's the axillary line we make for the side. Then the line on the back, the line on the back. So we still have posterior middle line. Very in the center, through the process of the vertebrae. That's the posterior middle line. And then we make two lines, follow the middle edge of the skeletal bone. Yeah, that looks like a skeletal bone in here. That's the middle range. That's the middle range. That's the middle range of the skeletal bone. So we make two lines here. We just name it scapular line. Yeah, scapular line. Pretty same when we talking about acupuncture meridian and the points. We talking about on the back, we have two lines for your blood channel. The first line is 1.52 away from the middle line. The second line just follow middle edge of the skeletal bone. That's about 3 inches away from the middle line. That's basically the same line in here. So that's some range and some line. Then we're talking about looking the organs on the superficial of the body. So basically from anterior part, certainly we have lung on both sides. Right side we have 3 loops. Yeah, we have 3 loops. Upper, middle, lower. And pay attention, the top of the lung is over the clavicle bone, 2 to 3 centimeters. So that's clinically we need to be careful. When we do needling around that area, pay attention not to go to wrong directions. Left side mainly still lung in there. Left side lung is a little bit smaller. It only 2 loops because we holding most part of our heart in the left side. So that's in final part, we have big part, that's the heart. Posterior, we're looking for the lung, pretty similar. Even right side lung is 3 loops, but posterior part, you can see just small part for middle lobe. Basically, other 2 parts pretty similar. And the lung, basically they will moving, follow the respirations. So inhale, lung getting bigger. Exhale, lung getting smaller. That's some movement we can see. And last week we talking about when we physical examinations, truly we can find the changing. That's just looking from side. Yeah, that's left side, that's right side. Some questions in here. So basically we're talking about respirations will be changing for the location or position of the lung. So right side certainly we have liver below the lung area. Lung moving, the liver will be moving. But basically we're checking mainly for the lung. It's not truly for the liver. So patient deep breathing, and then we're checking movement of the sounds changing. But how we can separate where is the lung? We must be find some dull sound, that's the liver sound. We are checking not for the liver, but the sounds coming from the liver. You can put your attendance during a break. Yeah, just questions when I talking. Yeah, and then if you have some questions, I can answer you. If you put your name there, like I always looking for the checking part. Yeah, put your checking during a break. Yeah. And then excuse me, my floor has some trouble here. Okay, good. Okay, then we're talking about the trachea. Trachea located in the front part of the chest, in the center. So that's truly we can find it. Yeah, we can find it. And when we're checking for the lung, we're checking for the trachea. And they have some bunch, but the bunch part, we couldn't touch it. But we can hear the sounds coming from trachea, coming from some bronchi tree. So that's basically some anatomy simple coming from the chest part. Then we follow the order. We checking for the chest area and checking for the lung. Inspection. Just looking. Just looking. Patient coming, and then we looking frontal part and the back part of the patient. So basically we're looking the shape changing, and if patient's chest moving with respirations, so both sides should be the same and the shape should be normal. That's from our inspirations. So the shape, certainly this one, both sides, anterior and posterior, look like pretty normal. And any of the others have different disorder. Maybe bone bigger from the anterior part, maybe bigger from posterior part, but generally it's kind of abnormal. From looking, we can find. That's inspection for the chest part. Then we're looking for palpation. Palpation is feel. Use the hand, feel the patient. So palpation the chest part. So we can try to find if patient has some tenderness on the skin. And also we can palpation. For follow the respirations, the chest will expansions, and also femur. So that's the week we're talking about. We have a picture later, I believe. Like we put our hand, we can do on the back part of chest area first, and leaving some small distance here, about 1 to 2 centimeters, and then tell the patient deep breathing. When patient deep breathing, the lung will expansion, and your fingers will moving away. Follow the lung expansion. So that if patient like have this kind of movement, and also two sides, the moving distance the same, that will be normal. That will be normal. Sometimes it's a patient the movements pretty smaller. Even your hard to find it. And maybe one side is moving away, another side is still on the original location. That's abnormal. So that's belong to palpation way. Use your hand. Femurs. That's still use your hand. Put on the patient's chest area, and then tell the patient speak something. Then we feel the vibrations through the hand. So that's the way, we call it pharmacy. So still like the picture here. So we say the doctors put hand on the chest area, and then tell the patient say, we can tell the like 999, and put a pretty long sound in there. We are easily feel the vibration. Or maybe 111. We just feel the vibration. What the patient say doesn't matter, but you must, like a patient say, let it be long sound in there. Then you can feel the vibration. Sometimes even E, still good. Still good. So that's feel the vibrations through the hand. We compare to do it both sides. Normally, the vibrations will be similar stronger on both sides. So we compare it. We compare it. from upper chest, go to middle, go to lower, then we go to the side. Then we compare. Both sides, same, basically, it's normal. Because the stronger, also depending how bigger the patient is, the muscles. So the same patient, both sides, the same will be normal. So that's the second way we're talking about the palpation. Then we're talking about the percussion, the third way. Third way is percussion. Percussion, we still use our hand, put on the patients, but we tapping for the patients and then we hear the sounds. It's not the feeling, not the feeling. Palpation is use our hand to feeling. Percussion use the hand make some sounds when we hear the sounds. So that's palpation, percussion. That's percussion. That's percussion. So we still go to picture here. So basically we have two basic ways to percussion. Two ways for percussion. We can use just one hand, just one hand. That's directly percussion. We can use two hands. That's indirectly percussion. When we do the percussion, okay, good. So when we do the percussion, we say one hand just tapping there. One hand just tapping there. So like I think you can see here, like this kind of tapping. That's directly percussion. That's directly percussion. And the indirectly percussion, I put one hand pretty close my skin here, and then use another hand tapping over it. Tapping over it. That's indirectly percussion. Indirect percussion. So we hear the sounds. We hear the sounds. So we still compare the sounds coming from both sides. If both sides are the same, should be normal. And we also talking about the lung. We'll have a special sounds between the hollow and the door. Thus we give it a special name, resonant. Resonant. It's not truly hollow, not truly dull sounds in there. That's resonant sound. If the organ, solid organ, like the liver, from the percussion, the sound will be dull sound. So how we can find, like how bigger is the lung? We just find the sound changing. So the line here means the sound changing from the resonant sound to the dull sound. I think that's the similar idea. Like sometimes you checking, like some people build up a building, and then they make certainly some wood in there, and between the wood and the wood, it's drywall in there. They totally cover. Now they try to like make a hugger in somewhere, put something in there. They must be put on the wood iron, not in the drywall iron. Drywall iron is not strong enough, so they need to try to find where is the wood. So that's the same way you can tapping there. Yeah, you can tapping there. Yeah, just tapping, and then you can like different sounds. You can hear the difference. Pretty similar. Yeah, pretty similar. So the sounds coming from the lung and the sounds coming back from the liver will be different. Yeah, liver just like the wood sounds. It's dull sound in there. And the lung look like the drywall cover part. That sound we call restless. So that we try to find the lower border of the lung. Yeah, we try to find the lower border of the lung, looking for the sounds changing. When people deep breathing, the lung sounds will go to lower. And when people breathing out, the lung will be shrinking and they will go to upper. So normally, the difference about 5 centimeters. That's normal movement of the lung. Like breathing in, breathing out, there will be some difference. Certainly, some people may be even more bigger. Bigger usually after patients or after people's exercises. Their lungs expanding weight is changing to bigger, but small usually means some illness. So that's still the same thing we look. So that's for the back chest part area. Yeah. Back chest. Yeah. We are not talking about aspirations. Aspirations mainly still for the lung. We're talking about aspirations later, especially go to the lung area. Then we checking anterior chest area. We still follow inspections. We're still looking for the shape, and we're still looking like both sides are pretty similar, and we're still looking the movement, follow the respirations. So that's pretty similar with the back area. The palpation, palpation, still find some tender area, and we also still find the chest expansions. We do on the back area. We also can do it in the anterior area to see the lung will be expansions when follow the respirations. So in anterior part, we still put 2 hands pretty close to the middle line, but some distance there, and ask patients deep breathing, and your finger will follow to move. That will be normal. That's normal. Both sides moving distance will be the same. That will be the normal. And certainly, we will talk about others later. But we go to here first. Yeah, certainly we still looking the parameters. Yeah, we still looking the parameters. Remember, parameters still use your hand, and then tell the patient speak something like 999, and then you can feel the vibrations under your hand. Then you compare both sides. That's the first location, second location, third location. But remember, second location in chest area may be little bit different with right area. Left side, right side, little bit different. Because left side will have heart there. That's still normal. So that this part pretty similar like we checking for the back. But for anterior part, we have something special here. Trachea. We say trachea should be located in the center. So that we can checking for the trachea. Put 2 fingers on both sides of the trachea and then looking the trachea if still in the center. If they in the center, that's normal. If it not in the center, that's abnormal. So that's anterior part a little bit special for palpation. Others pretty similar, like on the back. So that's basically the chest part. Then we especially go to the lung examinations. Lung examinations means we do something special for the lung. Inspection, we still follow inspection, palpation. We say lung will have 4 ways to checking, and third way, percussion, and then we still have 4th ways, aspirations. So physical examinations, totally, we have 4 different ways. Used for lung, we need all the 4 ways. Then we go back one by one. Inspections. We mainly focus with 3 parts. One part, respiration movement. Both sides should be the same. Second part, we're looking for the rate. Rate part, when we're talking about vital signs, basically we're talking about normal rate about 12 to 20 per minute. And it should be regular, regular. Not too deeper, not too shallow. That's the normal rate. And then we look in respiration, like still talking about the regular here. So that's from inspections, checking for the lung. Then we're talking about palpations. Palpations pretty same, like we're checking for the chest area. We're still looking for expansions, like follow the respiration. And we still feel the parameters, like tell the patient say 1, 1, 1, and then we can feel it. Both sides should be the same. Then we're talking about percussion. Truly, we can use directly percussion and indirectly percussion. But whatever percussion, the sounds coming from the lung, we call it resonant. The sounds is between the hollow and the dome, because those sounds coming from the solid organ, hollow sound coming from the old air inside. But the lung little bit special, small alveoli, and then some air inside. like a mix with the organs and the air. So that's why the sounds coming from between the dull sound and the empty sound. Thus we give a special name, resonate. Yeah, resonate. And the percussion, where we can find the long sound for resonant sound. So basically, upper border 2 to 3 centimeter over the clavicle bone, and the lower border, around 6 intercostal space, and we must be say in the middle clavicle line there. So by the patient's normal respiration, now deep breathing, now deep breathing in, now deep breathing out. And if the sound changing, yeah, that's the lung area, that's the lung area. If in the lung area, it changing from the resonant sound to the dull sound, thus must be some illness relationship to the solid kind of changing, like some tumor inside, some liquid inside. If the resonant sound changing to more empty or hollow sound, we use the words hyperresonance, means more hollow sound. That means must be more air going. We have some illness, more air go in, especially go to pleural cavity. Then the sound will be changing. And still the same picture, we say percussion and aspirations. Basically, we use this chart, compare both sides. Compare with the chart before we use for chest area. Look like we just have more dot here. Yeah, basically, we just compare both sides. Yeah, between the intercostal space and the intercostal space, and then we compare both sides. Then we go to the side of the chest area. Basically, pretty simple. Then the fourth checking way, auscultations. So that means we use scalp, and then we hear the sound coming from the patient. Thus, these two sides put to both sides of the ear. And these sides put on the patient, on the superficial skin of the patient. So through this tool, we can hear clearly inside of patients the sounds in there. So we say right now we have this kind of scalp, we can hear clearly. But in the ancient time, like start from beginning, truly doctors use the ear directly touching for the patients, and then try to hear the sound coming from the patients. Certainly that's not convenient. Yeah, that's not convenient. Then they use like a paper, roll a paper, and then put one side of paper to the patient, one side to the ear. Hear the sound. And certainly right now we use this kind of scalp. It's much easier. So we hear the sound coming from the patients, coming from the lung, coming from patients breathing. Basically, the sounds coming, the air passing through different part of the lung. Some part is narrow, some part is like more wide, and they coming with different sound, like some wind go to a room from the window. They make some special sound, woo kind of sound. So similar idea. So then we can separate the three normal sounds in there. In the lung area, all of the lung area, that's basically terminal area of the bronchial tree. Yeah. We say the bronchial tree, trachea area is much bigger. Then they go to let it be narrow, then more narrow, and then even small. Yeah. Pretty small area. That kind of sound is small sound in there. That sound we name it vascular. So that's in both part of the lung sound is vascular sound. Then we talking about the big bronchial tree here. Yeah, big bronchial tree here. Certainly, trachea area we have specially like a rough sound in there. We have another rough sound only in the trachea area. Then big bronchial tree connected with trachea area. That's we call bronchial bursting sound. Then between the big bronchial tree and between the alveoli area, basically we can got another sound we call bronchivascular bursting sound. Bronchivascular bursting sound you only can hear in some small area. You only can hear in the smaller area. We say you only can hear in the first and the second intercostal space because the lung tissue is pretty smaller there. And also back area, between the scapular bone area. So that's the bronchivascular sounds. And the vascular sound, most part of the lung. Then we say trachea, trachea, just over trachea area, means over the sternal bone area. And maybe little bit above sternal bone. We're talking about the sternal notch area. And then we talking about the bronchial sound. Basically still over the medulla bone there. And the sounds will be a little bit different. More softer, more loud, and they from softer to loud, or you can say from loud to softer, from trachea to the lung. So that's last week we hear a lot of sounds coming from the lung. Thus, remember, in the normal location we hear the sounds. That's the normal lung sound. If they changing, still some sick or illness maybe happens. We are not necessary to remember all the changing, but we need to remember all the normal sound in the normal location. So that's coming from last week. We talked about the checking for the chest and for the lung. Yeah, do we have any questions coming from last week? Then today we go to the heart. Yeah, today we go to the heart. Physical examinations for the heart. Certainly heart still in the chest area. But heart, we know, always jumping. And they jumping, they make some special kind of movement. And they make a special kind of sound. Thus, we talking about checking for the heart. We have some special way. So still cardio. Medical words for heart. Vascular, blood vessels. So it belongs to vascular, cardiovascular systems. But in this chapter here, we mainly checking for the heart. We have some chapter later, we checking for blood vessels disorder. So heart examinations, we still do inspections and palpations. We put these two parts together because something we can see, we also can feel it. And the heart examinations is more mainly part percussion. That's the third way, yeah. Percussion. And certainly we have fourth part, aspiration. So that we say we still use four ways to examinations for the heart. Inspection, palpation, aspiration, and the percussion. It should be percussion first. Yeah, percussion and aspiration. So let's talk in some detail of the heart examinations. So we still follow the order. Inspection and palpation. Truly looking for the heart, inspection and palpation, basically the same area. So we put it together here. Inspection and palpation. The first, we looking apex beat. What means apex beat? Means the top of the heart, the beating area. So let's still go to a picture here. So this is a picture. Yeah. Let's see, where is the heart? So that's basically the heart located area. And we're talking about the heartbeat around this area. That's we call apex area. So certainly, like a heart, they have blood vessels, mainly big blood vessels connected on like the upper part of the heart. So when heart contractions, the muscles go to this way. And the heart relax, the heart go to this way. So kind of a jumping there. Yeah, you can see like people don't have breast tissue and not too big muscles there. Sometimes we can see the heart jumping there. So that's the area we're looking to see the heart jumping in that area. And certainly if you put your hand there, you can feel the heart jumping in that area. So that's basically that area we're looking for the heart. Both inspections means we can see it sometimes. Yeah, I must say it's not everybody you can see it. Some of the patients you may see it, but you should be palpation. Yeah, should be palpation. So it should be normally located in the fifth intercostal space. That's one line there. And we must have another line meeting. Yeah. We say 0.5 to 1 centimeter in the middle side of the medial clavicle line. So that's still go to the chart here. That's the medial clavicle line. Yeah, medial clavicle line. We say that's clavicle bone. That's another side clavicle bone. Yeah. So picture sometimes is not that perfect. Yeah, but it should be in the middle. And then we make a line from there. Then we calculate the intercostal space. Second, third, fourth, and the fifth. And they talking about 0.5 to 1 centimeter. Means they calculated the center here and to the middle clavicle line. So that's distance 0.5 to 1 centimeter there. So that's we talking about location. Yeah, location. If we can see it, we will see it in this location. Or maybe we can palpation for it, like a heart jumping in that area. So that's location here. Then we're talking about how bigger. Scalp diameter means the jumping, how bigger in that area. 2 to 2.5. So still go by the picture here. So that means the diameter from here to here, 2 to 2.5. So like where we can find it and how bigger it normally it should be. So we're looking how bigger and how strongly we feel it. Yeah, we feel it, how bigger, how strongly. And also we're looking around that area. Is something normal or abnormal, but generally say we need to remember the location where we can find it and how bigger it is, yeah, how bigger scalp it is. So that's the mainly things. That's the mainly things. So that's on the patients basically located inferior for the male, yeah, for the male. For female, the nipple may be moving, but for the male patient, we say the nipple will located in the fourth intercostal space and in the middle clavicle line. So that will be inferior intermediately about 0.5 to 1 centimeter below 1 intercostal space. So that's the location there. And then we can palpate it. Yeah. Put the hand over that area and feel it. Yeah. Feel it is jumping stronger or not stronger. So inspection and the palpation part for heart, pretty simple. Yeah, pretty simple. Then we're looking, percussion. So percussion still use the hand tapping the skin, yeah, tapping the heart area. Then we hear the sounds coming from the heart. So what are we looking for, or what are we trying to hear from the heart, the sound there? So still coming back to this picture, we still say that's the heart location. So normally people heart more go to left side, yeah, more go to left side, but also cover the middle, yeah, middle chest area, but more go to left side, so that's heart. And around heart, it is the lung. Both sides, it is the lung. And certainly some rib will cover the heart also. So when we percussion, yeah, when we percussion for the heart, remember our fingers go to intercostal space, not go to the over rib area. If you go to the rib area, the sound will be different. But our fingers, put your fingers between the intercostal space and the intercostal space. We do indirectly percussion, means use another fingers, tapping your fingers. So left side fingers go to follow the rib cage, go to the intercostal space, and the right side fingers tapping left side. So like some people here, I put my hand here, mainly middle finger, follow the intercostal space there. And then another finger just over it. So then you can see some sound changing. And then you're moving from one intercostal space, go down, go to another intercostal space. Then you still hear the sound. So that's basically we're talking about percussion for the heart. So what kind of sounds we're looking for? Yeah, what kind of sounds we expected? So if we make the edge of the heart here, this side certainly left side, then our fingers moving. I put my fingers here first, and then I'm moving gradually, follow the intercostal space, gradually, moving this side. That means from beginning, I hear the sounds coming from the lung, and then I hear the sounds coming from the heart. Heart sounds 出来 is 导 sound, because it is solid organ. Lung sounds we talked about before. It's a half solid and half air inside. So that sounds we give a special name, resonance. So that means if I percussion from the lateral side to the center, I hear the resonance sounds first, then changing to down sound. That means that's the ending part of the heart. Then we follow the other rib. Then I will find how bigger of the heart or aging of the heart is this side. Then I go to other side. When I go to the other side, I do the same thing. I'm moving my finger from side part, go to center. When I passing the heart, the sounds will be changing from resonance to the down sound. So right side smaller compared with left side the heart. And we also have sternal bone here. So sometimes sternal bone will be cover some heart, but the sternal bone sounds still down sound. We're still thinking about that's the ending part of the heart, right side. So by this way, we can find some numbers. So that's for percussion, the numbers coming from. We're talking about through the normal percussion. Then we can find the left side, the borders, how centimeters away from middle line. So that's calculated from the middle line. Yeah, how centimeters away from the middle line. And we say normally people from middle line to the middle clavicle line is about 8 to 10 centimeters. I would like to say both sides, but we put the left side here because right side will not truly use. Heart mainly located in the left side. So thus we got some idea here, like how many centimeter idea here. But both sides from middle line to the clavicle line will be the same, 8 to 10 centimeter for different people. Let it be different. Yeah, big people, small people. Yeah. Then we're looking for left side border of the heart. In the second intercostal space, about 2 to 3 centimeter. In the third intercostal space, 3.5 to 4.5 centimeter. in the fourth intercostal space, 5 to 6 centimeter. In the fifth intercostal space, that's the bigger part, apex area, that's 7 to 9 centimeter. So that's the margin we're talking about. Apex is about 0.5 to 1 centimeter within the middle side of the middle clavicle line. So that's the margin of our pictures. Upper part, let it be smaller. Lower part or apex part is more bigger. So basically, that's the second intercostal space, third intercostal space. My picture a little bit bigger here. And then fourth intercostal space, fifth intercostal space. So that's getting bigger here, this side. Other side, we say most part is covered by the sternal bone. And the right side is smaller. So you can see, you can find in the second intercostal space and the third intercostal space basically the same, 2 to 3 centimeter. And the fourth intercostal space, 3 to 4, but you couldn't find in fifth intercostal space. So still go back the pictures. You can see the other side, in the second intercostal space and the third intercostal space, pretty similar. Fourth intercostal space, little bit bigger, and then they go to a curve there. Nothing happens in the fifth intercostal space. So that's through the percussion, truly we can find if patients sometimes heart sick or illness, they got a pretty big heart. Or maybe sometimes patient with some other issue like the tumors in the chest, or maybe lung issue like a lung shrink in this side. They will pull the heart moving to this side. Or maybe some big tumor on this side. They still push heart to other side. So like why is the heart size changing or heart location changing? Both sick or illness could be happen. So that's why we're looking for how bigger of the heart and where it located. Where it located. So different illness may cause the heart some like a size change, size changing, and also sometimes Percussion disorder. Some fluid go to the percussion. That's also can changing for the heart. And also we talk about some lung disorder. It's not truly make the heart getting bigger, but truly can move in the location of the heart for lung issues. And still coming from the percussion, we say we're losing some dog coming from the heart. Look like the heart area getting smaller. Heart bigger truly is heart disorder. But not people truly like a lifetime. Their heart can changing from bigger to smaller, coming from the illness. That means the illness coming from the lung. Is the some more air go to the lung, or maybe some air go to the pleural cavity or even pericardium? So that means they truly changing the sounds. Still this picture. Remember our heart located inside of pericardium. We can think about some pericardium have some disorder, affect the sounds of the heart, and also lung disorder or pleural disorder still affected the sounds coming from the heart. So thus we say heart, those sound changing, not only heart disorder. And possible is the lungs disorder, pleural disorder, and maybe pericardium disorder. So all of the organs around the heart will affect the sound changing. But liver, we say liver below the diaphragm. Liver disorder not affect the heart. Usually, they will getting bigger, go to downward, go to upward. It's a little bit harder. Diaphragm in there. So liver mainly cause the downward getting bigger. When we go to abdominal area, we're talking about liver. But here we mainly talking about heart. Affected the heart changing. That's mainly coming from the heart itself, or maybe coming from the pericardium around the heart, or maybe pleural cavity, or maybe the lung. And then the sounds changing. So basically, we will thinking about if we're still talking about if more air go to the lung, that's basically the lung sounds, lung getting bigger, and some of the lung cover the heart, especially left side. So that make the heart look like smaller here. We say heart down sound changing to smaller. Usually it's lungs problems or pleural problems cover the lung area. But the heart down sound getting bigger. That may be heart disorder. And also like some liquid go to pericardium, still possible, or liquid go to pleural cavity, still down sound. Remember, we separate the sound with down sound. That's basically anything solid inside is down sound. And then we talking about restless kind of sound. It's a half solid, half empty sound. That's mainly coming from the lung. And certainly later on stomach we talking about empty kind of sound, hollow sound. That's truly is air kind of sound. So the sounds will be changing. So that's mainly where percussion we can find. So that's even more important examination way compared with other examinations. So that's the scalp. We can see from the radio, we directly hear the sounds coming from the heart. So we say, we pick up some different location, then we hear the sounds. Let's still go to the picture first. What the heart sounds coming from? The heart sounds coming from blood circulation from atrium go to the ventricle. And then, so basically when the blood coming from the ventricle to the big blood vessels, we know inside the heart we have 4 valves. Yeah, 4 valves. So basically the sounds, heart sounds, coming from the valves closed. We know the blood circulations just go to one direction. The valves just look like a one door. When they open, blood passing through. But when they closed, then they make a sound. So that's we're talking about the sounds coming, And follow the blood flowing, the sounds will heard in the different location. So some location you hear some valves sounds more clearly compared with other locations. So that's the picture here. Here is the valves location. So that's trachea side valves. Certainly on the right side of the heart, connected like a right side atrium and ventricle between it. Yeah. That's on the left side valves. That's the valves, pulmonary valves. That's the aorta valves. So this picture tell us the valves location. This picture tell us where we can hear the sounds. Hear the sounds. So you can see it's a little bit difference. Yeah, little bit difference when we hear the sounds with its physical valves location. So that's basically follow the blood flowing, and the sounds is more easily heard on the superficial of the body. So blood flowing this way. So we can hear the sounds, tricuspid sounds in this location. And the same thing left side, these valves in here, but we hear the sounds more clear on the top of the heart area. And the aorta sounds, blood flowing this way and then go to aorta. So we can hear the sounds in this location. And the pulmonary artery, and the sounds travel go to this way. So that's why we hear the sounds in this location. So that's basically we hear the sounds by the physical location of the valves and how the blood transflowing from the valves to the superficie of the body. So that's the blood flowing way. Yeah. The blood go back from big vein to the right side of the atrium, and then through the valves go to right side of the ventricle, and from right side of the ventricle through the pulmonary valves here go to pulmonary. We talking about the tract here, but truly they go to separate with atrium both sides. That's the right side. Yeah, that's the right side. Left side, blood coming back from the pulmonary vein and then go to left atrium. From left atrium, go to left ventricle. From left ventricle, go to aorta. So this picture basically tells us blood flowing with the valves relationship. And the last picture, this one tells us the physical location of the valves and where we can hear the sounds coming from the valves. So thus we have especially where we hear the sounds coming from the valves for aspirations. So like the chart here, So we say if we try to hear the sounds coming from aortic valves, we need to go to right side of the sternal bone on the second intercostal space. So let's be matching with the picture here. So that's the valves located here, atrial valves, but the sounds transmission to here. So that's the first intercostal space, that's the second intercostal space. So we hear the sounds in here for the aortic valves. Yeah, for the aortic valves, we hear the sounds in here. And then we go to another valve here. If we try to hear pulmonary valves, we go to the left sternum, second intercostal space. So basically, they are in the same level, second intercostal space, but one is left side, one is right side. So that's second intercostal space, and on the sternal bone, thus we hear the sounds coming from the valves, pulmonary valve. Then we're looking for another tool. So number 3, we hear the sounds coming from a tricapsate valve. That means valves on the right side between the atrium and the ventricle. So we go to left side sternal border. So that's still valve's location, but the transmission, valve's location and the transmission, this picture still not valve's location, still here the location. Sorry, I make some mistake. Still here the location. So valve's location just in this picture. This one just on superficial of the skin where you hear the sound. So that's the valve's location. And the sound transmission, that's our hearing location. So just these two pictures is not truly matching here. Yeah, look like we hear the sound. It's a little bit lower. So this picture should be a little bit higher here. And then this picture should be a little bit lower here. That's then we can match it. Yeah. So this picture is not that truly perfect picture, but just give us some idea here. So that's the triceps valves. We hear the sounds coming from left side sternal border. Left side sternal border. So basically around the fourth intercostal space. Yeah, around the fourth intercostal space. Then we go to the last valve, mitral valve, right in the apex area. So that's we say apex area, but this heart, they drop a little bit bigger, should be like this. Yeah. So apex area, and then we can hear the sound in that area. So we're talking about the different location. Clinically, patient heart sounds changing, may be coming from different illness, maybe relationship with different valves. We close there, we try to identify is which valves they have some trouble there. But generally speaking, if you put scalp over the heart area, you will hear the heart sounds. If we not specially go to special kind of valves, you still can hear the heart sounds. So what's the heart sounds look like? Yeah. So we have normal heart sound, we have abnormal heart sound. And the heart sound go to different valves is a little bit different. But generally speaking, our heart jumping separate with two parts, systolic part and diastolic part. Systolic part is both sides of the heart. We say ventricle contractions. That's the big part of the heart. Both side ventricle contractions and make a systolic blood pressure, like we talked about blood pressure. We have upper number that belong to systolic, and the lower number belong to diastolic. Both side ventricle contractions, and at the same time they close the both sides of the valves between the atrium and the ventricle. Thus make a big sound here. And certainly ventricle muscles is more thinner, more stronger. When they contract, it's more powerful. So that's the big sounds coming. And when they pushing the blood go to aorta, more blood go to there, cause more pressure there. That's a systolic blood pressure coming from. So what's the sounds look like? Dong, da. The first dong is coming from the contractions of the both sides of the ventricle. So if we make some picture of valves here, so this one is more bigger. We call it the first sounds coming from the heart. Then we will have second one. Second one is smaller. That's coming from another two valves closed. That's the da. Yeah. But even normally, our blood flowing still have some small sounds may be coming, but it's not that clear. Some people you can hear it, some people you may not hear it, but still belong to normal. We may have the third sound. And we also can hear some even more smaller sounds that come from the atrium. But generally say, we clearly can hear two sounds. One is bigger and like a little bit high pitch. One is smaller, little bit small pitch. That's generally say we can hear two sounds. We can from bigger part of the heart area. You can try to put a scalp in front of the chest area. So basically, all over this area, you can hear the heart sounds. Certainly, if you go to the apex area of the heart, so basically in this area, the sounds is more clearly. Try to find your heart jumping in this area and then put a scalp to that area. Basically, everybody can hear the normal heart sounds. One is shorter, one is like longer in there. Dong da, dong da, dong da. So that's the normal heart sounds. Yeah, normal heart sounds. So that's we say we need to know where we can find the heart sounds and what's the normal heart sounds look like. And certainly if some special kind of valves, they have some trouble, then you can go to special kind of valves. You can hear the sounds more clearly. So that's just the relationship with different valves here. We are not necessary to go to that detail. We just try to remember the normal heart sounds. And also, so we say different illness, the heart sounds will be changing. So we still not go to that detail for different illness. We're still talking about the valves. We say the sounds coming from the valves closed. So the 6 sounds we just heard. So like normally the sound, the valve will be closed when the heart contractions. That's just left side. Yeah, just left side. So some sick or illness, the valves couldn't close. They have space between the valves. Means with heart contractions, some blood can flowing back. Certainly some blood still go to the aorta. But you hear the sounds, it's not the like if we close the door, it's pa, close the door. It's like a door is not closed and the blood flowing there. So that's the first sound, fu, and then second sound, ba. And then first sound, fu, ba. So that's the sound which is here. We go to another. So that's truly these valves troubles. Mitral valves, mitral valves trouble. So that's some sick or illness sounds. So that's just some example here. That's just some example here. It's not like detail. We are not go to that detail. That's truly pretty technique. Truly pretty technique. So checking for the heart, especially for heart sounds, need long-term practice. Truly need long-term practice. And then you can separate different kind of heart sounds. But we just talking about some ruler, about how we checking for the heart. I will suggest you, if you have scalp, try to hear some sounds coming from the lung and coming from the heart. So we are not truly like get a diagnosis from your checking, but truly you can separate normal sound and abnormal sound. And clinically, you still can use, scalp you still can use, even not belong to TCM, but still give us some suggestions for different kind of sounds. So that's basically for today. Today we're talking about cardiovascular systems. Cardiovascular systems examination. Mainly we go to the heart. We are not truly go to blood vessels. Mainly we go to the heart. And then we still follow the full way to checking examinations. So that's we put inspection and palpation together. So location, location, apex beat location we need to remember. And how big it is, we need to remember. So basically this part. And then that's just give you example here. This example here. Then this chart we need to remember. For percussion, heart examinations for percussion, like the border of the heart, left side and right side. That's the right side. That's the left side. The number we need to remember. In which intercostal space and how big it is. And the normally from the middle line to the middle clavicle line, what's the normal number there? We need to remember. We are not truly try to remember different disorder, but your understanding. If more air go to there, the heart down sound will be smaller or lucid. If more solid in there, the heart down sound will be getting bigger. including the heart issue, including some other issues. And the dislocation, dislocation usually is the lung issue or percussion issue. And the location, location for aspirations. We hear the different vowels in different location and understanding it. Understanding why we go to there. So that's basically follow the blood transmission way and the blood flowing to that area. So understanding few picture here. And understanding where the sounds coming from. We say normal we can hear two sounds. First sound is closed mitral valve and the transept valve. And certainly including ventricle contractions. But ventricle contraction is not make a big sound. And then we're talking about the second sound. Second sound is the closed aorta, aorta kind of valves, and pulmonary valves. So that's where the first sound and the second sound coming from. Occasionally we can hear the third sound, but sick third sound and normal third sound certainly is different. We are not go to that detail.